Hello everyone. Welcome to this concise guide on managing eye and ear problems and symptoms in a community pharmacy setting. Let us start with conjunctivitis, one of the most common ocular conditions encountered in community pharmacy practice. Conjunctivitis refers to inflammation of the conjunctiva and may be caused by bacterial infection, viral infection, or allergy. As pharmacists, your role is to differentiate between these types based on clinical features and determine whether OTC management is appropriate or referral is required. Careful history taking is essential. You must assess which eye is affected, the nature of discharge, associated symptoms, and the severity of presentation. When differentiating types of conjunctivitis, several key clinical features should be evaluated. In bacterial conjunctivitis, both eyes may eventually be affected, but typically one eye becomes involved first within 24 to 48 hours. The discharge is purulent, meaning thick and yellow or green. Patients often describe a gritty sensation. In viral conjunctivitis, both eyes are commonly affected, and the discharge is watery. It is frequently associated with upper respiratory tract symptoms such as cough and cold. In allergic conjunctivitis, both eyes are involved simultaneously. The discharge is watery, but the distinguishing feature is itching. Redness tends to be more prominent in the fornices, and it is often associated with rhinitis. These differences are very important for examination purposes. Viral conjunctivitis is highly contagious. There is no specific over-the-counter antiviral treatment available. Management is primarily supportive. Patients must be counseled on strict hygiene measures, including frequent hand washing, avoiding touching or rubbing the eyes, and not sharing towels or cosmetics. Referral to a doctor is generally recommended. Although antibiotics do not treat viral infection, they may sometimes be prescribed to prevent secondary bacterial infection. In allergic conjunctivitis, treatment aims at symptom relief and prevention. Mast cell stabilizers such as sodium chromoglycate are considered prophylactic agents. They must be used continuously during allergen exposure. The usual dose is 1 to 2 drops in each eye, 4 times daily. It is suitable for patients aged 6 years and above. Sympathomimetic eye drops such as nefazoline may be used for short-term relief. The dose is 1 to 2 drops, 3 to 4 times daily. Combination preparations containing antihistamines and decongestants, such as antazoline with xylometazoline, may also be used. However, prolonged use of sympathomimetics should be avoided due to the risk of rebound hyperemia. Bacterial conjunctivitis should be referred to a doctor for appropriate antibiotic therapy. OTC management alone is not sufficient. Prompt treatment helps prevent complications and limits transmission. As pharmacists, you should not attempt to manage confirmed bacterial conjunctivitis without medical evaluation. Certain symptoms require immediate referral. These include clouding of the cornea with associated vomiting, which may indicate glaucoma, irregularly shaped pupils or abnormal response to light, photophobia, severe eye pain, and distortion of vision. These red flags suggest potentially serious ocular pathology and must never be managed at the pharmacy level. Always remember, mild conjunctivitis may be managed conservatively, but any atypical or severe presentation requires urgent medical assessment. Let us now discuss dry eye, a very common complaint encountered in community pharmacy practice. Dry eye results from either reduced tear production or excessive tear evaporation. The most common cause is keratoconjunctivitis sicca, or KCS, which accounts for the majority of cases. In this condition, there is dysfunction of the tear-producing structures, leading to chronic dryness. It is important to note that this condition has no definitive cure. Management is symptomatic, primarily with artificial tears. Another important cause is Sjogren's syndrome, an autoimmune disorder characterized by dryness of the eyes and other mucous membranes, particularly the mouth. The presence of both eye and mouth dryness is a key diagnostic clue and requires referral. Blepharitis is another cause. It is typically bilateral and presents with irritation, burning, itching, red eyelid margins, crusting, and eyelids sticking together in the morning. This condition also requires referral. Finally, dry eye may be medication-induced. Common offending agents include diuretics, anticholinergic drugs, isotretinoin, selective serotonin reuptake inhibitors, and beta blockers. A thorough medication history is therefore essential. Management of uncomplicated dry eye primarily involves artificial tear preparations. Polyvinyl alcohol eye drops are commonly used, with a standard dosing of 4 times daily. Sodium hyaluronate eye drops may also be used and are typically administered on an as-needed basis. These agents act by lubricating the ocular surface and improving tear film stability. They provide symptomatic relief but do not cure the underlying condition. Students should remember, treatment is supportive and often long-term in chronic cases such as KCS. Referral is required in certain situations. If the patient reports dryness of both the eyes and the mouth, Sjogren's syndrome must be suspected, and referral is mandatory. If symptoms suggest blepharitis, such as red, inflamed eyelid margins, crusting, irritation, or eyelids sticking together, referral is also required for appropriate management. Persistent, worsening, or atypical symptoms should always prompt further evaluation. When more than one ophthalmic preparation is prescribed, patients should wait at least 5 minutes between applications. This prevents dilution and ensures proper absorption. Contact lens wearers should discontinue lens use during treatment and for at least 48 hours after completion. Preservatives in eye preparations may damage lenses and worsen irritation. In summary, dry eye is commonly managed in the pharmacy setting, but recognition of red flags and correct patient counseling are critical responsibilities of the pharmacist. Proper counseling on eye drop administration is essential in pharmacy practice. First, the patient must wash their hands. Second, tilt the head backward and look upward. Third, gently pull down the lower eyelid to form a small pocket. The dropper should be held close to the eye without touching it to avoid contamination. Instill one drop into the lower eyelid pocket, then close the eye gently. Any excess fluid should be wiped away with a clean tissue. Correct technique improves efficacy and reduces risk of infection. For eye ointments, the initial steps are the same: hand washing and pulling down the lower eyelid. A thin line of ointment should be placed along the inside of the lower eyelid. The patient should then close their eyes and move the eyeball side to side to distribute the ointment evenly. Temporary blurred vision is expected after application and resolves with blinking. Remember that ointments are usually applied at bedtime due to this blurring effect. Let us now review earwax, also known as cerumen, which is one of the most common causes of temporary conductive hearing loss encountered in community pharmacy. Patients may present with reduced hearing, a sensation of blockage, discomfort, or fullness in the ear. It is important to understand that earwax itself is a normal physiological secretion that protects and lubricates the ear canal. However, excessive accumulation can lead to obstruction. This condition is generally benign and manageable at the pharmacy level unless complications arise. Management of impacted earwax involves softening the wax to facilitate natural expulsion. Commonly recommended options include olive oil or proprietary cerumenolytic eardrops. Before administration, the drops should be warmed to approximately body temperature to avoid dizziness or discomfort. The correct procedure is as follows. The patient should tilt the head to the side, instill 5 drops into the affected ear, and insert a cotton wool plug to retain the fluid. The plug should remain in place for at least 1 hour or preferably overnight. This process should be repeated twice daily for 3 days. An important counseling point is that hearing may initially worsen as the wax softens and swells. Patients must be warned about this to prevent unnecessary anxiety. Patients must be strongly advised not to use cotton wool buds or any objects to clean inside the ear canal. This practice pushes wax further inward and may cause trauma or perforation of the tympanic membrane. If symptoms persist after 3 days of proper treatment, referral to a doctor is advisable. The physician may consider ear irrigation, also known as ear sironing, to remove the remaining wax. In summary, earwax impaction is a common and manageable condition in pharmacy practice, but appropriate counseling and recognition of treatment failure are essential. Let us now discuss inflammations of the ear, otitis externa and otitis media. It is extremely important to differentiate between these two conditions because their location, symptoms, and management differ significantly. Otitis externa involves inflammation of the external ear canal, whereas otitis media involves inflammation of the middle ear. Clinical presentation will guide you toward the correct diagnosis. Otitis externa is inflammation of the skin lining the ear canal. It may be localized, presenting primarily with ear pain, or diffuse, where symptoms include pain, itching, hearing loss, and discharge. On examination, the ear canal and sometimes the external ear appear red and swollen. The most common cause is bacterial infection, although fungal infections may also occur. Predisposing factors include ear trauma, swimming, often referred to as swimmer's ear, chemical exposure, ear sironing, and underlying skin conditions. In cases of otitis externa, referral to a doctor is generally required to prescribe an appropriate antibiotic, such as flucloxacillin. However, if the patient cannot access medical care immediately, certain OTC options may be considered temporarily. Acetic acid 2% spray has antibacterial and antifungal properties. It works by acidifying the ear canal, creating an unfavorable environment for pathogens. It can be used in adults and children aged 12 years and older. The recommended dose is 1 spray, or 60 mg, into the affected ear at least 3 times daily. Treatment should not exceed 7 days. Analgesics such as oral paracetamol may be used for pain relief. A local acting analgesic such as choline salicylate spray may also be recommended. Students should remember that OTC therapy is temporary and does not replace medical assessment. Otitis media is inflammation of the middle ear. It commonly follows an upper respiratory tract infection. The mechanism involves blockage of the eustachian tube, which connects the middle ear to the nasal cavity. This blockage leads to fluid accumulation in the middle ear, creating an environment favorable for bacterial growth. Unlike otitis externa, otitis media is typically associated with systemic symptoms. The symptoms of otitis media include ear pain, temporary hearing loss, and usually a high temperature. Patients often present with concurrent cold symptoms. On otoscopic examination, the tympanic membrane appears red or yellow and bulging. If the tympanic membrane ruptures, mucopurulent discharge may occur, and pain often decreases due to pressure relief. The presence of fever and systemic symptoms helps distinguish otitis media from otitis externa. Management of uncomplicated otitis media is primarily symptomatic. First-line treatment consists of analgesics such as oral paracetamol or choline salicylate spray. Antibiotics are not routinely recommended because most cases resolve spontaneously within 3 days. Unnecessary antibiotic use contributes to antimicrobial resistance. However, referral is essential if the patient is immunocompromised, for example, diabetic, or if pain persists beyond 3 days. As a pharmacist, your responsibility is to support rational antibiotic use while ensuring patient safety. To summarize, otitis externa affects the external ear canal and often requires referral for antibiotic therapy, though temporary OTC measures may be used. Otitis media affects the middle ear, is commonly associated with systemic symptoms, and is usually managed with analgesics unless complications arise. This concludes our overview of common eye and ear problems and symptoms management in community pharmacy practice.